completed her bachelor's in international relations and her master's in public health from Grand Canyon University in Phoenix, Arizona. She is also a graduate of development project management from Monterey Institute of International Studies. She is a licensed trainer of cultural competency in healthcare and human services from the Cross-Cultural Healthcare Program. Ms. Khatka is the founder and cultural competency consultant at Hamro America. On today's webinar, Ms. Khatka is going to talk more about how low health literacy and health disparity affects our clients and what we can do to help them. So without further ado, I'm going to go over and turn it to Ms. Khatka.
Hello, everyone. Can you hear me? Well, I guess they can. Hello again. My name is Kamana Khatka. Today I'll be presenting on understanding low health literacy and health disparities. And this is a pro bono webinar for Ethiopian Community Development Council. And thank you for this opportunity. I'm very happy to be among yourselves. So let's move on to the webinar. So today's agenda is diversity defined. We will talk a little bit about low health literacy. We will also talk about health disparities and the importance of culturally and linguistically appropriate services. So the objectives for today's workshop is to establish a clear and shared understanding of the concepts of diversity and culture, to establish an understanding of the impacts of low health literacy and health disparities, and to establish the importance and relevance of culturally competent and linguistically appropriate services. And before we move on to our webinar, to our presentation, let me warn you, these topics are very vast, and my presentations on just health literacy would be 3-4 hours. As you may know, a lot of you work on health disparities and you work with diversity, so you know how vast these topics are. So today we will just be scratching the surfaces, but my goal is to get you thinking and give you a clear understanding, a little bit of clear understanding of those topics. I always start my workshop with some inspiration. Inspiration is very important in our lives. So an inspiration for us today would be from Dr. Martin Luther King Jr. Of all the forms of inequality, injustice in health is the most shocking and the most inhumane. So moving on, let's start defining diversity. What does diversity, we all talk about diversity so much, so what does this diversity look on a demographic scale in our country, in the United States? So about 25 to 30% of the United States population self-identified as belonging to an ethnic or racial minority group. U.S. Census predicts this figure will rise by 47.5% by 2050. That is a huge increase in the diversity population, diverse population. 33 states for which the Census Bureau has released 2010 census counts of Hispanic, they accounted for 58% of population growth over the decade. And a lot of you work with the refugee communities. So in 2009, during 2009, 74,602 persons were admitted to the United States as refugees. And that's the number of persons, but then the languages, the cultures they all bring, it's a lot. The leading countries of nationality for refugees in 2011 were Burma, Bhutan, and Iraq. I personally am very close to the Bhutanese population because we speak the same language, Nepali. So moving on more on the changing demographics in the United States, approximately 45 million persons with physical and mental impairment are the single largest minority group. And a lot of time we kind of, when we talk about minority groups and when we talk about diversity, these numbers are not something that, that pops up in our heads. There is a dramatic rise in longevity, there will be a dramatic rise in longevity that will result in 1 in 5 people being over 65 by 2050. So we'll be dealing a lot with the elderly population, and by this, you should be aware the difference of culture, the generation gap, the cultural gap that we will be facing by 2050. By 2030, 1 in 4 elderly persons will be from a racial or ethnic minority group. By 2030, it is projected that Hispanics or Latino population, 65 and older, will increase by 328%. That is a lot. And the Asian and Pacific Islander population, 65 and older population, will increase by 285%. So this is a map that shows where most of the diverse population live. And now moving on to the still on demographics, but the adult literacy data. So we will talk a little. We'll talk a little bit about health literacy, but I wanted to, as we're talking about demographics, I wanted to share some of this demographic data as well. So 40 million Americans cannot read complex text. That was a shocking number to me when I found out. Only 12% of English-speaking adults in the United States have proficient health literacy skills. Another shocking number, it's only 12%, and these people speak English. So when there are people that speak fluent English, they're accessing healthcare services or our services, we hand them different paperworks. That's the first thing we do at any organizational level. We hand them different paperwork, fill out the insurance information, fill out this and that without knowing, okay, they speak English, but can they read and write English? So that's one step ahead in kind of shaping our thoughts. Half of all American adults have difficulty understanding and acting upon health information. Nearly 9 out of 10 adults have difficulty using the everyday health information that is routinely available to our healthcare facilities, retail outlets, media, and communities. So now, with this demographics, with this diversity in our population, how do people access the health information, right? So 18% of the U.S. residents over age 5 speak a language other than English at home. 21 to 23%, or some 40 to 44 million of the 191 million adults in the U.S. have extremely limited reading and quantitative skills, almost level 1. 60% of the Medicaid population, which is a majority of our refugee population that we serve, has low literacy. 25% did not know diagnosis or name of a drug when asked. 50% did not know the purpose of the drug, and 75% could not describe their disease. I also work as a Nepali interpreter for some of the Bhutanese, non-English speaking Bhutanese, and at a health center, at different health centers. And these are some of the things that I almost always encounter is even when explained about the medicine doses, it's almost, verbatim them is almost not enough because they have never done some of the things. So now, what is this health literacy and why is it important? So what is health literacy, first of all? The degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decision is defined as health literacy. Again, focus on the points: obtain, process, and understand the health information. So low health literacy may result in the inability to understand written instructions on prescription drug bottles, appointment slips, medical education brochures, doctor's direction and consent forms, and ability to negotiate complex healthcare systems. So these are some of the things that can be a result of low health literacy that we might see in our clients. So who are at risk of this low health literacy? Mainly the elderly population, people with low income, because generally people with low income might not have access to schools. They might not be literate, unemployed, did not finish high school, minority ethnic groups, new non-English speaking immigrants, and those born in the United States but English is their second language. And these are general criteria. These are general scanning degrees. So now, what is health disparity? I always think of health disparity as it equals to health inequality. There was an example given at one conference which is stuck to my head is health disparity is health inequality is like you are distributing shoes. You see that there are people, you are wearing shoes, there are people that are not wearing shoes. So you're distributing shoes because there is inequality in the community. You think everybody needs shoes like I did. But then when you're distributing those shoes, you have the capacity to distribute those shoes. But when you're distributing those shoes, you are not checking on what size fits those people. So you're distributing like shoes that you think might fit the needs of those people, that might fit their feet, right? So that is health disparity. I take that as health disparity. So we are here, we are trying to meet the inequality, we're trying to make everything equal, yet we are not really thinking about what the community might need or what the community we are serving, what are their needs, how do they define their needs, and hence we end up creating this disparity. And that is also the case with a lot of healthcare. When these differences exist, they are referred to as disparity. We see this when racial and ethnic minorities receive lower quality health care than whites, right? It is important to understand that differences in race and ethnicity, among other things, will always exist. We cannot get rid of the differences in ethnicity and race. It will always exist. It is wrong, however, when these differences lead to unequal care. So what are some of the disparities found in healthcare? So we consistently found across a wide range of disease and areas and clinical services. They are found even when clinical factors such as a stage of disease, presentation, comorbidities, age, and severity of diseases are taken into account. And disparities in care are associated with higher mortality among minorities. So there was a report by the Institute of Medicine in 2002 which stated racial and ethnic minorities tend to receive lower quality health care than whites do, even when insurance status, income, age, and severity of the conditions are comparable. So again, on the disparities in health, infant mortality for blacks is twice the rate of the whites. Cancer deaths among Latinos and blacks are disproportionately high. Cervical cancer is 5 times more likely to strike Vietnamese women as white women. And Native American have a higher rates of diabetes and health diseases. And minorities are less likely to be immunized and less likely to be tested routinely for cancer, less likely to have regular medical checkups. And a lot of times when we work with the refugee population, I have heard a lot of people that work with the refugee population kind of state that they're not used to going to the doctors. They're not used to like taking care of the health. So everything is new for them. Well, yes, it is new for them, but the refugees they go through so many things, starting from their home countries to the country, their third third country where they were in the refugee camps and coming to this country, a resettled country like United States. They go through a lot, and their worldview is so broad, and they adapt to a lot of things. So with this medical checkup, like not getting used to it, they also adapted. I mean, a lot of the refugee camps have those services, have doctors at the camp that do a lot of medical checkups. So it's not like they have never been used to it. They were already used to it, but when they come to United States, because of the language gap, because of the cultural gap, the lack of interpretation services, they don't go for medical checkups because it's just not comfortable and sometimes not manageable at all. So and that's one of the reasons why these checkups are they are less likely to do the checkups, and something that could be improved by organizations that work with this population. So what are the factors that contribute to health disparities? Sometimes behavioral choices are something that we just discussed about the not going to the regular health checkups, genetic predisposition, nutrition, access to medical care, environmental and occupational condition, low literacy, and poverty are some of the factors that contribute towards this health disparity. And then some of the other factors are also, what are the barriers to communication in healthcare? And this could also be the factors that contribute to health disparities. Linguistic barrier. People, if they are not provided with qualified interpretation services, if the language is not provided, they are not able to communicate with the doctor, to the healthcare provider. Hence, that's a barrier. Barrier of register. Even if there are refugees, I mean, there are a good amount of refugees that speak very good English, but if the doctors, let's say, speak in a very high register, they might not be able to understand it. So barriers to register. Some of the cultural barriers. There are like a lot of cultural barriers. The Western biomedicine, the hospitals have a culture of their own, and the patients have the culture of their own, and oftentimes they clash. And if those barriers are not intentionally met, if the systems don't really think about how to overcome those barriers, then it always remains, and that's another thing. The systemic barrier. I'll give you an example to a systemic barrier. If a non-English speaking person calls a number, like the first thing they get, I mean, I live in Arizona. I was helping out I'm very close to the Bhutanese refugee population, and one of the refugee kids, Bhutanese kids, he was 20 years old and into substance abuse. He happened to, a lot of them have my phone number, so they called me and asked me to take them to a healthcare center because they could not get through. Even after giving them the phone number in Nepali and everything, they just and they could not get an appointment. And the reason why was because they would dial the number. The first thing that they would hear is the option as English or Spanish. There is no other option. So there is, you know, that barrier that just they cannot. The way the system has created the barrier, in order to make an appointment, they have to call first. But you know, when you call, you cannot really talk because there is nothing provided in your language. So a system, when it's created like that, very unthoughtfully, it becomes a barrier. So poor communication in patient-provider interaction, it creates disruption, it reduces loyalty, it reduces confidence, it diminishes compliance. So now moving on more on the language portion, like a lot of the refugee serving agencies deal with this, I'm sure. One of the Latino interviewers said, we have lots of fears. We don't speak English, they don't listen to us, and it's frustrating to know that it means they can do what they want and we can't do anything about it. it is also frustrating that I don't have the money to be able to take classes to learn English. And that's another thing. I mean, when we serve our refugee friends, we deal with other people commenting a lot on why don't they learn English first? Why don't they go to English classes? Well, it takes, for an average person, it takes about 3 to 4 years to learn English and to be fluent in English. But even when they're fluent, they can speak simple sentences. And if you take them to the hospital where the doctor speaks in high register, that might be a barrier for them. So it takes about 7 years for somebody to be fully fluent in another language, not just English. So one of the things I wanted to kind of define was interpreting and translation. And the reason I want to define these terms is because these are always used. These are two terms that are always mixed. Interpreting is the spoken word. Translation is written. So when we refer to interpreters, they're most of the times referred as translators. Translators write, interpreters speak. So interpreting is the process of understanding and analyzing a spoken or signed message and re-expressing that message faithfully, accurately, and objectively in another language, taking the social and cultural context into account. And translation is the conversion of a written text into a corresponding written text in a different language. So it's written and spoken. So that's the difference. So now a lot of refugee agencies I have seen and a lot of other organizations use ad hoc interpreters because, I mean, they're nonprofit organizations, they don't have funding, they cannot pay for a trained interpreter, they cannot pay for interpreter training, and a lot of those things, I mean, could be excuses, could be the reality, but whatever it is, we need to overcome this. So let me give you some of the things that will help you make decision to why you should use a professional interpreter versus ad hoc interpreter, okay? So professional interpreters result in a significantly lower likelihood of errors of potential consequences than ad hoc or no interpreters at all. Among professional interpreters, hours of previous training but not years of experience are associated with error, numbers, types, and consequences. These findings also suggest that requiring at least 100 hours of training for interpreters might have a major impact on reducing interpreter errors and their consequences in healthcare while improving quality and patient safety. And there needs to be additional research in medical interpretation training. So we also use a lot of bilingual staff. So there are staff, especially in diverse organizations serving diverse populations, staff that are bilingual and bicultural. So, but being bilingual does not make you an interpreter. We need to understand that. Being bilingual does not make you an interpreter. When you pull your staff members that are not trained to be an interpreter to interpret, you're putting them in a really, really difficult position because interpretation needs specialized skills. Language proficiency has to be tested, and training is required. So when you're pulling a bilingual staff to interpret for a client that has never gone through any interpretation training, you're first thing making them very nervous. Second thing, you're probably putting your clients could be life sometimes in jeopardy, right? So we need to think about that. And then another trend I've seen is the use of family members. So, oh, the father, the mother doesn't speak English, but the child speaks pretty good English because he's attending high school. So why not use the child as an interpreter? That's appropriate, right? A lot of agencies think that. But why should you not use family members, right? They often edit patients' message heavily. I mean, if I was interpreting for my mom, if my mom says something like a long sentence, I'm not going to say everything. I kind of get the gist of it, and I will give you like some bit of it. And they add their own opinion. Sometimes the mom says something and, oh, that's probably not correct. I want to make myself look good. Or, you know, they start adding their own opinion. No, this is not like this, mom, it's like this. And then they answer for the patients. I've seen this multiple times. And it impedes development of patient-provider relationship. And the confidentiality issue, what about the confidentiality issue? We talk about confidentiality, the HIPAA law, and all of those things over and over again. But when you make a family member interpret, what about the confidentiality issue? They're rarely trained. Accuracy, completeness, and impartiality, it's highly questionable, okay? Now, what about the children? So why should we not use children as the interpreters? And there is guilt if child does not convey message correctly. If child feels he is a source of suffering because he says something painful, there is a guilt on that child. You're contributing that. You're contributing towards that. That's a horrible feeling. You might be also traumatizing the child. Children are often traumatized if they are required to pass bad news or are held responsible for negative outcomes. I've met a lot of people that have interpreted as a child before. I mean, it still is a trend now. People still use children as interpreters, but please don't do that. Don't put the child in that situation. Put yourself in the shoes of the child and think, you know, how would you feel if you were to do that as a child? So now, what are some of the qualities of the skilled medical interpreters? Like, why should you even use a qualified and skilled medical interpreter? First thing a skilled medical interpreter needs to have is the fluency in 2 languages. They have the fluency in 2 languages. They have training in interpreting techniques. They have specialized vocabulary in 2 languages. The knowledge of medical procedure, they have that. They have the ability to adjust dialect and register. They have the ability to process meaning, find equivalency in the second language, and express it fluently in the other language. They have excellent memory skill and attention to detail, and all of these are acquired skill. I mean, they have to work for those skills. They have to go through training, and these interpreters, the qualified interpreters, certified interpreters, practice those. So what are some of the roles of the medical interpreter? So the basic purpose of the interpreter is to facilitate understanding and communication between people who are speaking different languages, right? So that is the basic purpose of the interpreter. But I've seen at especially the refugee organizations, the resettlement organizations, a caseworker is used as an interpreter, is used as a transporter. I mean, there's a lot of things that a caseworker is used as. So, and most of the time, these caseworkers are not even provided with any interpretation training. I'm actually in the process of working with one of the resettlement agencies to provide interpreter training to the existing staff, which is, I mean, a good step. Interpreters also facilitate, it implies an active rather than a passive role. Understanding the role of an interpreter is also to foster understanding, not simply repeating words, but to make sure the message is understood. And communication, so implies that transfer of information can and does not happen on several levels besides the spoken word. So there are body languages that, you know, the interpreters can interpret, and different things. So I just wanted to show you this kind of this pyramid to give you you know, the roles of an interpreter. Is the first role is a conduit. So you're just transferring one information from one point to the other, exactly how it's said. So if a doctor says something, you're interpreting that exactly in the other language to the patient. Clarifier, there are certain things where, you know, you need clarifications. The doctor needs clarification, the person needs, the client needs clarification. So the interpreter's role is also to clarify. and act as a cultural broker. I'm sure a lot of us know that interpreters also act as a cultural broker, but also advocate. I mean, we, you know, when a non-English speaking person accesses services, not all services are serve them good or treat them good. So there are certain cases where an interpreter is the only one that has been exposed to that. So there is, you know, a need for that advocacy piece as well. And the interpreters, your interpreters are, you know, can also serve as advocates. So now a cultural, I'll give you a cultural competency, a more practical view of what cultural competency is, what diversity is, what does it mean to be culturally competent. So to be culturally competent, it doesn't mean that you are an authority in the values and beliefs of every culture. What it means is that you hold a deep respect for cultural differences and are eager to learn and willing to accept that there are many ways of viewing the world. So this brings me to the end of the presentation. I want to take this moment to talk a little bit about my company, Hamro America. So Hamro is a Nepali word which means ours. And our vision is pretty simple: culturally competent service for all, disparities for none. Our mission is, sorry, I forgot to change the slide. Our mission is to strengthen culturally competent services in America such that people with diverse needs receive sensitive, knowledgeable, and non-judgmental access. We define diverse needs as abilities and disabilities, cultural and linguistic, social, and healthcare. And what we do at Hamro America is we provide trainings and consultation on introduction to cultural competency, advanced cultural competency trainings. We also provide 45-hour of introduction to interpretation trainings and continuing education trainings for interpreters. A lot of times we think just by providing 45-hour of interpretation training is enough, but that is not enough, because if you're sending your interpreters to you know, the interpreters work at a school, a hospital, court, social care, all at the same time. So imagine all of the vocabularies that change, and all of the things that you need to keep up with. So these continuing education trainings are very important for interpreters. And lastly, I would like to close with do a closing thought. This is a story. I bring this story to you from New Delhi, India. This is where I really understood what culture is strategy. So, you know, working with the refugee population, I've done that since 2005. I closely worked with the refugee population, and a lot of times when I was very immature with this population, a lot of times a thought crossed my mind where I thought, you know, their culture and their language, because they're not able, a lot of them are not able to speak English. It's a barrier, you know, but you can really use culture as strategy. Is because so this woman in New Delhi, India. So New Delhi is India is mostly a country of the Hindus, right? Hindu religion is very prominent in India, and in Hindu religion, cow is a sacred animal. So this woman lived in the outskirts of Delhi. So if you not really the outskirts, but if you go to Delhi, there is just this road. A road where the cars run, and on one side of the street there are tall buildings and, you know, business complexes, and the other side you will see the slum area. So it's that close to each other. So this woman from one of the slum area, but saw the you know, big skyscraper buildings, and saw people coming down, the businessmen and the entrepreneurs and professionals coming down. Saw her, and she kind of understood the culture of her city. So what she did was she knew, you know, cow is sacred, and feeding the cow in Hindu religion, feeding the cow is considered you're gaining good karma. So this woman brought her cow, parked at one of the streets close by these buildings, the business buildings, and she cut grasses from her backyard, and she put the grasses, and she sat 3 feet away from the cow with a heap of grass with her. So these people, as they come down from the buildings for lunch or whatever, they would look at the cow, they see the grass on the side, and they would buy the grass from the woman, and they would feed the cow and gain good karma for themselves, but really making money for this woman, who I think is a super entrepreneur, because the investment was almost close to nothing, and she was making money, and people were paying money to feed her own cow. People were paying her money to feed her own cow from her own backyard, the grass from her own backyard. So that, I mean, understanding culture could be, could be really, really interesting. And if this woman, who has never been to school, who doesn't have an MBA degree, can do so much by understanding a simple culture of her city, imagine how much in America can we do by understanding the cultures of the people that come here. With that, I will leave you to this is my contact information. Please feel free to contact me for any cultural competency related or interpretation related training needs you have. There's my website. We also have a blog and a Facebook page, if you don't mind liking it. We do post lots of good information there. And at this point, I guess we're open to questions. And again, I'm sorry, I have these topics are, it's very, I do more of in-person presentations, so it's more livelier and there are a lot more interactions. With webinar, in a way, it's very good, but in another way, we are very limited. And plus, the topics we chose for today are very vast and probably was not able to cover everything, but now we're open to questions if you have any.
Thank you, Ms. Kaka, for the presentation. Just a reminder to everyone, please use the chat function to enter your questions. There was a question. Were you able to see it?
Oh, is the question, are there any tools to assess low literacy rate, or do healthcare workers use any tool? I'm not aware if there are any tools yet to assess the low health literacy. This is a very good question. I've not come across any tools, and I haven't seen any healthcare workers use any tools to do that. But that's something that raises a very important need in the field. Basically, the other question is, when working with clients, what are some common indicators of low health literacy? So again, the indicators, they are not very prominent, but again, like we talked about somebody being an elderly from a low income family, unemployed, did not finish high school, minority ethnic group, recent immigrants to the U.S. But who do not speak English, born in the United States, but English is their second language. So these are some of the indicators themselves. So when you come across those people, maybe like asking them, not not in a very confronting way, but like kind of asking them politely if they can read and write English would be a good thing.
Thank you. I have another question from Carrie, Carrie Spear. She says, I'm the coordinator of an interpreter program. Do you have any tools or suggestions for training medical interpreters that my interpreter training could use during his session of training new interpreters?
Tools for training interpreters.
Mm-hmm.
Yes, definitely. We have lots of really great tools for training interpreters. We have I don't know what type of training Carrie provides. How long is the training? But I'm sure. I mean, if she can connect with me later after offline, I can definitely help her figure out some of the tools for interpreter training. I mean, we have a really good training materials from Monterey Institute of International Studies. From Bridging the Gap program, and we have lots of good continuing education trainings for the interpreters that I can definitely share.
Then there's another one about providing copy of the PowerPoint presentation. This PowerPoint is being recorded, and it will be available on the ECDC's YouTube webpage. So, and I think Ms. Kharka was, she's willing to share a one-page, you know, all the pointers, so we can definitely make that available. Is that okay, Ms. Kharka?
Yes, sure.
Any other questions that people have? There is another one. Do you know if topics such as low health literacy or health disparity are included in nursing or medical curriculum?
It depends from school to school. I have seen universities include those topics, and I have seen a lot more not include those topics too. But it really depends from, you know, a university to university. But these topics are getting the focus. Like, I mean, they're coming. You know, people are slowly learning about it, and they're learning the importance of it.
If we don't have any more questions, then we will go ahead and close the session. So I would like to thank Ms. Kharka for your time, and I would also like to thank all the attendees for participating. I hope you found the webinar helpful. And like I said earlier, it has been recorded, so it will be available on our YouTube page. And I will be sending out a brief survey, so be on a lookout for that. Thank you.
Okay, thank you very much for having me.